C. Very impermanent drugs may also bind to cell surface receptors, dark binding sites, be engulfed by the cell membrane, endocytosis, and then released inside the cell or expelled via the membrane-limited vesicles out of the cell into the extracellular space, exocytosis. D. Barriers that separate these compartments. For a drug given orally to produce an effect in the central nervous system, these barriers include the tissues that make up the wall of the intestine, the walls of the capillaries that perfuse the gut, and the blood-brain barrier, the walls of the capillaries that perfuse the brain. Finally, after bringing about its effect, a drug should be eliminated. Effect. A drug should be eliminated at a reasonable rate by metabolic inactivation, by excretion from the body, or by a combination of these processes. A permeation drug permeation proceeds by several mechanisms. Passive diffuse ion in an aqueous or lipid medium is common, but active processes play a role in the movement of many drugs, especially those whose molecules are too large to diffuse readily. Figure 1 to 5. 1. Aqueous diffusion. Aqueous diffusion occurs within the larger aqueous compartments of the body, interstitial space, cytosol, etc., and across epithelial membrane tight junctions and the endothelial lining of blood vessels through aqueous pores that in some tissues permit the passage of molecules as large as mW 20,000 to 30,000. Asterisk see figure 1 to 5a. Aqueous diffusion of drug molecules is usually driven by the concentration gradient of the permeating drug, a downhill movement described by Fick's law, see below. Drug molecules that are bound to large plasma proteins, e.g., albumin, do not permeate most vascular aqueous pores. If the drug is charged, its flux is also influenced by electrical fields, e.g., the membrane potential and in parts of the nephron the transtubular potential. 2. Lipid diffusion. Lipid diffusion is the most important limiting factor for drug permeation because of the large number of lipid barriers that separate the compartments of the body. Because these lipid barriers separate aqueous compartments, the capillaries of the brain, the testes, and some other tissues are characterized by the absence of pores that permit aqueous diffusion. They may also contain high concentrations of drug export pumps, MDR pumps, see text. These tissues are therefore protected or sanctuary sites from many circulating drugs. Lipid aqueous partition coefficient of a drug determines how readily the molecule moves between aqueous and lipid media. In the case of weak acids and weak bases, which gain or lose electrical charge-bearing protons, depending on the pH, the ability to move from aqueous to lipid or vice versa varies with the pH of the medium, because charged molecules attract water molecules. The ratio of lipid-soluble form to water-soluble form for a weak acid or weak base is expressed by the Henderson-Hasselbalch equation, described in the following text. See figure 1 to 5b. 3. Special carriers. Special carrier molecules exist for many substances that are important for cell function and too large or too insoluble in lipid to diffuse passively through membranes, e.g., peptides, amino acids, and glucose. These carriers bring about movement by active transport or facilitated diffusion and, unlike passive diffusion, are selective, saturable, and inhibitable. Because many drugs are or resemble such naturally occurring peptides, amino acids, or sugars, they can use these carriers to cross membranes. See figure 1 to 5c. Many cells also contain less selective membrane carriers that are specialized for expelling foreign molecules. One large family of such transporters binds adenosine triphosphate, ADP, and is called the ABC, ADP binding cassette, family. This family includes the P-glycoprotein or multi-drug resistance type 1, MDR1, transporter found in the brain, testes, and other tissues, and in some drug-resistant neoplastic cells, table 1 to 2. Similar transport molecules. From the ABC family, the multi-drug resistance-associated protein, MRP, transporters, play important roles in the excretion of some drugs or their metabolites into urine and bile and in the resistance of some tumors to chemotherapeutic drugs. Several other transporter families have been identified that do not bind ADP but use ion gradients to drive transport. Some of these, the solute carrier SLC family, are particularly important in the uptake of neurotransmitters across nerve-ending membranes. The latter carriers are discussed in more detail in Chapter 6. For endocytosis and exocytosis, a few substances are so large or impermanent that they can enter cells only by endocytosis, the process by which the substance is bound at a cell surface receptor. Section I. Basic Principles 10. Table 1 to 2. Some transport molecules important in pharmacology. Transporter. NetCert. VMAT. MDR1. MRP1. Physiologic function. Norepinephrine reuptake from synapse. Serotonin reuptake from synapse. Transport of dopamine and norepinephrine into adrenergic vesicles in nerve endings. Pharmacologic significance. Target of cocaine and some tricyclic antidepressants. Target of selective serotonin reuptake inhibitors and some tricyclic antidepressants. Target of reserpine and tetrabenazine. Transport of many xenobiotics out of cells. Leukotriene secretion. Increased expression confers resistance to certain anti-cancer drugs. Inhibition increases blood levels of digoxin, confers resistance to certain anti-cancer and antifungal drugs. MDR1, multi-drug resistance protein 1, MRP1, multi-drug resistance associated protein 1, NET, norepinephrine transporter, SERT, serotonin reuptake transporter, VMAT, vesicular monoamine transporter. Engulfed by the cell membrane, and carried into the cell by pinching off of the newly formed vesicle inside the membrane. The substance can then be released inside the cytosol by breakdown of the vesicle membrane, figure 1 to 5d. This process is responsible for the transport of vitamin B12, complexed with a binding protein, intrinsic factor, across the wall of the gut into the blood. Similarly, iron is transported into hemoglobin synthesizing red blood cell precursors in association with the protein transferrin. Specific receptors for the transport proteins must be present for this process to work. The reverse process, exocytosis, is responsible for the secretion of many substances from cells. For example, many neurotransmitter substances are stored in membrane-bound vesicles and nerve endings to protect them from metabolic destruction in the cytoplasm. Appropriate activation of the nerve ending causes fusion of the storage vesicle with the cell membrane and expulsion of its contents into the extracellular space. See Chapter 6. B. Fick's law of diffusion. The passive flux of molecules down a concentration gradient is given by Fick's law, where C1 is the higher concentration, C2 is the lower concentration, area is the cross-sectional area of the diffusion path, permeability coefficient is a measure of the mobility of the drug molecules in the medium of the diffusion path, and thickness is the thickness, length, of the diffusion path. In the case of lipid diffusion, the lipid aqueous partition coefficient is a major determinant of mobility of the drug, because it determines how readily the drug enters the lipid membrane from the aqueous medium. See ionization of weak acids and weak bases. The Henderson-Hasselbalch equation. The electrostatic charge of an ionized molecule attracts water dipoles and results in a polar, relatively water-soluble, and lipid-insoluble complex. Because lipid diffusion depends on relatively high lipid solubility, ionization of drugs may markedly reduce their ability to permeate membranes. A very large percentage of the drugs in use are weak acids or weak bases. Table 1 to 3. For drugs, a weak acid is best defined as a neutral molecule that can reversibly dissociate into an anion, a negatively charged molecule, and a proton, a hydrogen ion. For example, aspirin dissociates as follows. A drug that is a weak base can be defined as a neutral molecule that can form a cation, a positively charged molecule, by combining with a proton. For example, pyrimethamine, an antimalarial drug, undergoes the following association-dissociation process. Note that the protonated form of a weak acid is the neutral, more lipid-soluble form, whereas the unprotonated form of a weak base is the neutral form. The law of mass action requires that these reactions move to the left in an acid environment, low pH, excess protons available, and to the right in an alkaline environment. The Henderson-Hasselbalch equation relates the ratio of protonated to unprotonated weak acid or weak base to the molecules pKa and the pH of the medium as follows. This equation applies to both acidic and basic drugs. Inspection confirms that the lower the pH relative to the pKa, the greater will be the fraction of drug in the protonated form. Because the unchanged ARC form is the more lipid-soluble, more of a weak acid will be in the lipid-soluble form at acid pH, whereas more of a basic drug will be in the lipid-soluble form at alkaline pH. Chapter 1 Introduction 11. Table 1 to 3 Ionization constants of some common drugs. Drug pKa1 Drug pKa1 Drug pKa1 Weak acids weak bases, content, acetaminophen 9.5 albuterol, salbutamol, 9.3 isoproterenol 8.6 acetazolamide 7.2 allopurinol 9.4, 12.32 lidocaine 7.9. Ampicillin 2.5 alprenolol 9.6 metaraminol 8.6 aspirin 3.5 amiloride 8.7 methadone 8.4 chlorothiazide 6.8, 9.42 amiodarone 6.6 methamphetamine 10.0. Chlorpropamide 5.0 amphetamine 9.8 methyldopa 10.6 ciprofloxacin 6.1, 8.72 atropine 9.7 metoprolol 9.8. Chromalin 2.0 bupivacaine 8.1 morphine 7.9 ethacrynic acid 2.5 chlordiazepoxide 4.6 nicotine 7.9, 3.12. Furosemide 3.9 chloroquine 10.8, 8.4 norepinephrine 8.6 ibuprofen 4.4, 5.22 chlorpheniramine 9.2 pentazocine 7.9. Levodopa 2.3 chlorpromazine 9.3 phenylephrine 9.8 methotrexate 4.8 clonidine 8.3 physostigmine 7.9, 1.82 methyldopa 2.2, 9.22 cocaine 8.5 pilocarpine 6.9, 1.42. Penicillamine 1.8, codeine 8.2, pindolol 8.6, pentobarbital 8.1, cyclizine 8.2, procainamide 9.2, phenobarbital 7.4, desipramine 10.2, procaine 9.0, phenytoin 8.3, diazepam 3.0, promethazine 9.1, propylthiouracil 8.3, diphenhydramine 8.8, propranolol 9.4, salicylic acid 3.0, diphenoxylate 7.1, pseudoephedrine 9.8, sulfadiazine 6.5, ephedrine 9.6, pyrimethamine 7.0 to 7.33, sulfapyridine 8.4, epinephrine 8.7, quinidine 8.5, 4.42. Theophylline 8.8, ergotamine 6.3, scopolamine 8.1, tolbutamide 5.3, fluphenazine 8.0, 3.92, strychnine 8.0, 2.32. Warfarin 5.0, hydralazine 7.1, terbutaline 10.1, imipramine 9.5, thioridazine 9.5. 1. The pKa is the pH at which the concentrations of the ionized and non-ionized forms are equal. 2. More than one ionizable group. 3. Isoelectric point. Application of this principle is made in the manipulation of drug excretion by the kidney. Almost all drugs are filtered at the glomerulus. If a drug is in a lipid-soluble form during its passage down the renal tubule, a significant fraction will be reabsorbed by simple passive diffusion. If the goal is to accelerate excretion of the drug, e.g., in a case of drug overdose, it is important to prevent its reabsorption from the tubule. This can often be accomplished by adjusting urine pH to make certain that most of the drug is in the ionized state, as shown in figure 1 to 6. As a result of this partitioning effect, the drug is trapped in the urine. Thus, weak acids are usually excreted faster in alkaline urine, weak bases are usually excreted faster in acidic urine. Other body fluids in which pH differences from blood pH may cause trapping or reabsorption are the contents of the stomach and small intestine. Breast milk, aqueous humor, and vaginal and prostatic secretions, Table 1 to 4. As suggested by Table 1 to 3, a large number of drugs are weak bases. Most of these bases are amine-containing molecules. The nitrogen of a neutral amine has 3 atoms associated with it plus a pair of unshared electrons. See the display that follows. The 3 atoms may consist of 1 carbon, designated R, and 2 hydrogens, a primary amine, 2 carbons, and 1 hydrogen, a secondary amine, or 3 carbon atoms, a tertiary amine. Each of these 3 forms may reversibly bind a proton with the unshared electrons. Some drugs have a 4th carbon-nitrogen bond. These are quaternary amines. However, the quaternary amine is permanently charged and has no unshared electrons with which to reversibly bind a proton. Therefore, primary, secondary. Section I Basic Principles 12. Interstitium pH 7.4. H. 0.001 milligrams. 0.398 milligrams. Rn. H+. HRN+. Cells of the nephron. Lipid diffusion H. Urine pH 6.0. H. Rn. H. 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 Rn plus H. H. 0.399 milligrams total. H. 0.001 milligrams. H plus. 10 milligrams. 10 milligrams total. Figure 1 to 6 trapping of a weak base, methamphetamine, in the urine when the urine is more acidic than the blood. In the hypothetical case illustrated, the diffusible unchanged dark form of the drug has equilibrated across the membrane, but the total concentration, charged plus unchanged dark, in the urine, more than 10 milligrams, is 25 times higher than in the blood, 0.4 milligrams. And tertiary amines may undergo reversible protonation and vary their lipid solubility with pH, but quaternary amines are always in the poorly lipid-soluble charged form. Drug groups. To learn each pertinent fact about each of the many hundreds of drugs mentioned in this book would be an impractical goal and, fortunately, is unnecessary. Almost all the several thousand drugs currently available can be arranged into about 70 groups. Many of the drugs within each group are very similar in pharmacodynamic actions and in their pharmacokinetic properties as well. For most groups, 1 or more prototype drugs can be identified that typify. Table 1 to 4 body fluids with potential for drug trapping through the pH partitioning phenomenon. Body fluid urine breast milk jejunum, ileum contents stomach contents prostatic secretions. Range of pH 5.0 to 8.0 6.4 to 7.62 7.5 to 8.03 1.92 to 2.592. Total fluid, blood concentration ratios for sulfadiazine, acid, pKa 6.5, 1. 0.12 to 4.65 0.2 to 1.77. Total fluid, blood concentration ratios for pyrimethamine, base, pKa 7.0, 1. 72.24 to 0.793.56 to 0.891.23 to 3.54 0.1146.45 to 7.42 vaginal secretions 3.4 to 4.23 0.21 0.114 0.94 to 0.79 85,993 to 18,386 3.25 to 1.02 2,848 to 452 1 body fluid protonated to unprotonated drug ratios were calculated using each of the pH extremes cited. A blood pH of 7.4 was used for blood drug ratio. For example, the steady-state urine-blood ratio for sulfadiazine is 0.12 at a urine pH of 5.0. This ratio is 4.65 at a urine pH of 8.0. Thus, sulfadiazine is much more effectively trapped and excreted in alkaline urine. 2 Lentner C., Editor Gege Scientific Tables, Vol 1, 8th ed. Siba Gege, 1981. 3 Bowman W.C., Rand M.J., Textbook of Pharmacology, 2nd ed. Blackwell, 1980. 4 Insignificant change in ratios over the physiologic pH range. Chapter 1 Introduction 13. The most important characteristics of the group. This permits classification of other important drugs in the group as variants of the prototype, so that only the prototype must be learned in detail and, for the remaining drugs, only the differences from the prototype. Sources of Drug-body interactions. The interactions between a drug and the body are conveniently divided into two classes. The actions of the drug on the body are termed pharmacodynamic processes. Figure 1:1. The principles of pharmacodynamics are presented in greater detail in Chapter 2. These properties determine the group in which the drug is classified, and they play the major role in deciding whether that group is appropriate therapy for a particular symptom or disease. The actions of the body on the drug are called pharmacokinetic processes and are described in Chapters 3 and 4. Pharmacokinetic processes govern the absorption, distribution, and elimination of drugs and are of great practical importance in the choice and administration of a particular drug for a particular patient, e.g., a patient with impaired renal function. The following paragraphs provide a brief introduction to pharmacodynamics and pharmacokinetics. Pharmacodynamic principles. Most drugs must bind to a receptor to bring about an effect. However, at the cellular level, drug binding is only the first in what is often a complex sequence of steps. Drug, D, plus receptor effector, R, rightward arrow drug receptor effector complex rightward arrow effect. D plus R rightward arrow drug receptor complex rightward arrow effector molecule rightward arrow effect D plus R rightward arrow DR complex rightward arrow activation of coupling molecule rightward arrow effector molecule rightward arrow effect inhibition of metabolism of endogenous activator rightward arrow increased activator action on an effector molecule rightward arrow increased effect. Note that the final change in function is accomplished by an effector mechanism. The effector may be part of the receptor molecule or may be a separate molecule. A very large number of receptors communicate with their effectors through coupling molecules, as described in Chapter 2. A types of drug receptor interactions. Agonist drugs bind to and activate the receptor in some fashion, which directly or indirectly brings about the effect. Figure 1-3a. Receptor activation involves the change in conformation in the cases that have been studied at the molecular structure level. Some receptors incorporate effector machinery in the same molecule, so that drug binding brings about the effect directly, e.g., opening of an ion channel or activation of enzyme activity. Other receptors are linked through one or more intervening coupling molecules to a separate effector molecule. The 5 major types of drug receptor-effector coupling systems are discussed in Chapter 2. Pharmacologic antagonist drugs, by binding to a receptor, compete with and prevent binding by other molecules. For example, acetylcholine receptor blockers such as atropine are antagonists because they prevent access of acetylcholine and similar agonist drugs to the acetylcholine receptor site. And they stabilize the receptor in its inactive state, or some state other than the acetylcholine activated state. These agents reduce the effects of acetylcholine and similar molecules in the body, figure 1-3b, but their action can be overcome by increasing the dosage of agonist. Some antagonists bind very tightly to the receptor site in an irreversible or pseudo-irreversible fashion and cannot be displaced by increasing the agonist concentration. Drugs that bind to the same receptor molecule but do not prevent binding of the agonist are said to act allosterically and may enhance, figure 1-3c, or inhibit, figure 1-3d, the action of the agonist molecule. Allosteric inhibition is not overcome by increasing the dose of agonist. B. Agonists that inhibit their binding molecules. Some drugs mimic agonist drugs by inhibiting the molecules responsible for terminating the action of an endogenous agonist. For example, acetylcholinesterase inhibitors, by slowing the destruction of endogenous acetylcholine, cause cholinomimetic effects that closely resemble the actions of cholinesterase agonist molecules even though cholinesterase inhibitors do not bind or only incidentally bind to cholinesterase. See Chapter 7. Because they amplify the effects of physiologically released agonist ligands, their effects are sometimes more selective and less toxic than those of exogenous agonists. C. Agonists, partial agonists, and inverse agonists. Figure 1-4 describes a useful model of drug-receptor interaction. As indicated, the receptor is postulated to exist in the inactive. Chapter 1 Introduction 7. Drug. C. B. Agonist. Competitive inhibitor. Receptor. Plus. Response A plus C. Effects. A alone. A plus B. Log dose. Allosteric activator. D. Allosteric inhibitor. A plus D. Figure 1-3 drugs may interact with receptors in several ways. The effects resulting from these interactions are diagrammed in the dose-response curves at the right. Drugs that alter the agonist, A, response may activate the agonist binding site, compete with the agonist, competitive inhibitors, B, or act at separate, allosteric, sites, increasing, C, or decreasing, D, the response to the agonist. Allosteric activators, C, may increase the efficacy of the agonist or its binding affinity. The curve shown reflects an increase in efficacy. An increase in affinity would result in a leftward shift of the curve. Non-functional form, Ri, and in the activated form, Ra. Thermodynamic considerations indicate that even in the absence of any agonist, some of the receptor pool must exist in the Ra form some of the time and may produce the same physiologic effect as agonist-induced activity. This effect, occurring in the absence of agonist, is termed constitutive activity. Agonists are those drugs that have a much higher affinity for the Ra configuration and stabilize it, so that a large percentage of the total pool resides in the Rad fraction and a large effect is produced. The recognition of constitutive activity may depend on the receptor density, the concentration of coupling molecules, if a coupled system, and the number of effectors in the system. Many agonist drugs, when administered at concentrations sufficient to receptor effector systems to the maximum extent of which the system is capable, that is, they cause a shift of almost all of the receptor pool to the Rad pool. Such drugs are termed full agonists. Other drugs, called partial agonists, bind to the same receptors and activate them in the same way but do not how high the concentration. In the model in figure 1 to 4, partial agonists do not stabilize the Ra configuration as fully as full agonists, so that a significant fraction of receptors exists in the Rad pool. Such drugs are said to have low intrinsic efficacy. Thus, pindolol, a beta-adrenoceptor partial agonist, may act either as an agonist, if no full agonist is present, or as an antagonist, if a full agonist such as epinephrine is present. See Chapter 2. Intrinsic efficacy is independent of affinity, as usually measured, for the receptor. In the same model, conventional antagonist action can be explained as fixing the fractions of drug-bound Ri and Ra in the same relative amounts as in the absence of any drug. In this situation, no change will be observed, so the drug will appear to be without effect. However, the presence of the antagonist at the receptor site will block access of agonists to the receptor and prevent the usual agonist effect. Such blocking action can be termed neutral antagonism. 8 Section I Basic Principles. Effect RRAI. RI, D. Response. DD. RA, D. RA plus RI. Effect. RA plus D full agonist. RA plus DPA. Partial agonist. RA plus DAN plus RI plus DAN constitutive activity antagonist RI plus DIG. Lock dose. Inverse agonist. Figure 1 to 4 a model of drug receptor interaction. The zoom 2 conformations. In the R
liquid.